again on the show, and Mr. Gibran Maher. Today we will be talking on a very interesting topic, the topic we usually not entertain or not know much about: the making of spine implants, innovation, manufacturing, and impact. Today we have the co-host on Vertebral Views show, Dr. Piyush Gadegone, globally trained spine surgeon, as well as Dr. Angelica Arce. She is a young, promising spine surgeon, currently in final years of her residency. We both welcome our co-host. And just to introduce our host, Dr. Mike Selby is a globally very well-known, renowned spine surgeon for his minimally to maximally invasive spine surgeries and his enthusiasm for education. He has trained and keeps training young surgeons as well as the seasoned spine surgeons. He is trained in Canada as well as Australia. He is very famous among his patients as well as among the spine field. Apart from his clinical work, operating room, and teaching the spine surgeons, he enjoys spending time with the family, playing and watching sports like basketball and cricket, as well as spending time on LinkedIn annoying other spine surgeons. We welcome Mike on the show.
Thank you very much, Raj. Thank you to the whole team at SpineTV and OrthoTV. Good to be here, and good to see Gibran as well. I see him all the time here in Adelaide. Adelaide's not a big place, as you know.
Yeah, I know. And we also welcome Mr. Gibran Maher. He's the CEO and co-founder of the Additive Surgicals, advancing 3D printed implants. He has a global experience in device commercialization, regulatory approvals, and advanced manufacturing. He specializes in translating surgical concepts into market-ready innovations that impact patients worldwide. It's lovely to have you and learn from you, Mr. Gibran, and we welcome from Vertebral Views show to you.
Thank you for me. I'm really excited to be here. I am passionate about medtech, manufacturing, and advancing medical devices to improve patient outcomes. So, yeah, really excited to be invited along. Thank you.
Perfect. So we'll go ahead with your presentations, followed by a few questions, and then presentation of Dr. Mike Selby. So all over to you, Dr. Mike Selby and Mr. Gibran. Let's start. You
Sure.
can share the screen.
So, Dr. Selby, what are your thoughts on why spine surgeons should understand the manufacturing and design of spinal implants?
Okay, that is a great question, Angelica. I mean, I think you can have the attitude of, well, you trust industry, you trust the company you work with, you trust your mentors that taught you how to do things, and just blindly accept what we're given in the operating room, or you can actually sort of dive into why and how these implants work, and how the whole process of spinal fusion occurs. And I do think, I mean, orthopedics, we get trained on that really well. I train neurosurgeons as well, and the ones that are interested understand it. But the basics of bone biology is probably not as much in their curriculum as it is for orthopedic trainees. Certainly are teachable, and certainly neurosurgeons that are keen can learn on how it all works. But I think we really have to get an understanding of how fusion occurs, and then how that relates to the implants that we use, both in the interbody space, but also the fixation devices that we use, and how these implants can make a big difference. I think there is something to be said for good surgical technique. There is absolutely no doubt about that. But even good surgical technique will not get you a fusion 100% of the time. Good surgical technique may also involve really invasive procedures. I think if you look at the good old days, you could get almost anyone to fuse by putting in implants, plus harvesting most of their iliac crest, plus putting the patient in almost a full body cast or brace for 6 months. Yes, most people fused, but that is not the sort of acceptable treatment that we have today with modern demands and modern lifestyles. People don't want that. People want to get back to doing things quickly. So we have to have that in our mind as well. And this whole swing towards minimally invasive surgery is driven about a rapid return to patient function. It's not driven by small incisions. It's not driven by surgical ego. It's driven by getting our patients back to function quickly. And an effect of that is, less muscle dissection, less tissue damage, etc. But I think when we're doing these techniques, we certainly lose some of those abilities that we had in the past to put in, say, huge volumes of bone graft to get patients to fuse. And so then we have to look and say, well, what is our aim with fusion? It's a solid arthrodesis. And how can we achieve that through smaller incisions, through, in more challenging patients? And the other flip side of this is that we're being expected to operate on older and older individuals. And I think that's a worldwide phenomenon, is that people have better health for longer, they're living longer, but their bone health doesn't always follow their general health. And, we're getting asked to operate on these older patients who are increasingly demanding and a more demanding fusion environment for us to get our devices to work properly. And so I do have very specific thoughts on this. I think people have seen me rabbiting on about what's good and what's bad online and on LinkedIn and other forums. I think some of the science behind it needs to be discussed now by Gibran. So I think it'd be good to see some of the processes that he uses in 3D manufacturing of titanium implants, which honestly at the moment I think is the best thing we've got in fusion.
Thank you, Dr. Selby, for a brief overview of the topic today. Now handing over to Dr. Gibran and Mr. Gibran, and waiting for him to enthrall us with this brilliant presentation.
Wonderful, thank you. I might just share some slides so I can go through to give some pictorial around my commentary. So I'll just share those slides with you now. So as you can see, the making of spine implants it's a difficult thing. Additive Surgical has come together to really focus on using additive manufacturing in the best possible light to create some complex geometries for spinal fusion. Additive Surgical was founded about 5 years ago. We came together because we wanted to use additive manufacturing and all of its capability to advance spinal devices. We work in Australia with a group of clinicians to really understand what's important to them and what's important to their patients. The team that we've got together has got over 100 years of dedicated medtech manufacturing experience cumulatively. It's interesting to have a little bit of a look at the history, right? So this will inform where we've come from and where we're going. Back in the 70s and 80s, allograft was used as a lumbar cage, and they had about 50% success rates. Then cylindrical metal cages were made, and these were developed first for horses and then in humans, and this sort of gave rise to the modern style of interbody cage that we start seeing today. We then moved to PEEK cages, and PEEK cages were, they were really good because they were a lot softer. The modulus of elasticity in a PEEK cage is around 4 GPa, so it was a lot softer, and we were seeing less of the vertebral fractures and less of the subsidence that machined metal cages used to sort of see. Then PEEK cages became coated with titanium and plasma sprays because PEEK inherently is hydrophobic. Bone protein doesn't grow on it very well. Bone doesn't grow onto the material very well. So coating PEEK cages with the titanium spray helped address some of those challenges. More recently, we've seen the rise of 3D printed titanium cages. Now, titanium's fantastic because it's, the reference material for biocompatibility. But with 3D printing, what we can do is we can really dial in some of the nuances of the cage which are important for fusion. So the modulus of elasticity is very important, so we can dial that in. And what we can see in this next slide is we got together to talk about what's important from a clinician perspective for their patients. What are we aiming for? So what would the ideal implant look like? So some of the metrics that came up when we were having these conversations, which led to our deep research and development, was the modulus of elasticity needs to be around 1 to 4 GPa, so that of bone. We want the porosity in the cage to be fully communicating, so all of the pores connecting to allow bone to grow on and through the cage, which in a lot of the 3D printed titanium implants at the moment, it's not fully communicating, or they're not fully interconnected pores. The pore size ideally wants to be from 100 to 1,000 micron, and that will encourage early and new bone and then stronger bone down the track. Having a biomimetic lattice, we talked about and did a lot of research and development into. And biomimicry is the science of using what's already existing in nature and replicating that in a structured element. We also identified that, potentially using two different lattices distinctly in the one cage to address specific functions could be a good idea. So we've done a lot of research and development into this area where we have developed two distinct lattices to put into one cage. So when we were going through a lot of the research and development into different lattices and what's important, you'll notice that a lot of the spine cages out there at the moment, the lattice in those spine cages are pretty standard repeating isometric lattices. So you'll see a lot of the cages have got a standard wave or a standard geometry that just repeats over and over. One of the reasons this has become quite popular is it's pretty easy to manufacture. So when you've got a standard repeating isometric lattice, the manufacturability is very high. It's quite easy to get to market, and it works, right? It's 3D printed titanium. But looking through some of these lattices when we were doing a deep dive into it, we noticed a few things, right? The modulus of elasticity can be quite good, but then when you put a big frame around it, the modulus changes and it becomes a little bit stiffer. Some of the other repeating isometric lattices, you couldn't have the irregularity of pore size. So something that the clinical team was driving is being able to have irregularity in pore size, like trabecular bone, right? That's not a standard repeating isometric lattice. That has smaller pores and bigger pores. So this is where we really wanted to head. So after going through a bunch of these standard repeating isometric lattices, where we ended up was biomimicry, right? So this is exciting because biomimicry really is looking at what exists in nature, not reinventing the wheel, but using additive manufacturing in every essence to try and come up with something better. So what we really looked at was looking at trabecular bone, how that forms, the structure of trabecular bone, and the organic nature of trabecular bone. So we spent 2 years. We researched more than 30 lattices in total and did a deep dive with a reasonable team of engineers and researchers. These are some of the lattices we printed in cubes. We then established a facility with everything in-house to test modulus elasticity, to test capillary action, like can it wick blood up, to test how dense it is, to test total porosity, all of these metrics that we said, this will make the ideal spine implant. We just went and we didn't stop until we found what we thought were the ideal lattices. So these are some of the examples of the prints that we did, looking at an organic structure, looking at that sort of trabecular style. What we ended up landing on after going through more than 30 lattices was these two lattice structures here. So the lattice on the left is called a perforated TPMS. It's very sort of grippy, right? It feels like Velcro, the hook and eye loop connector. So we sort of look at that as Velcro for the end plates. So that lattice contacts the end plates of the vertebral bodies. And then in the middle of that Velcro for the end plates, we've got the blue lattice on the right. And that blue lattice on the right is orthofoam. So that's structured very much like trabecular bone. It's got a regularity in its pore size and it's fully communicating. There's no dead ends, right? So blood can keep going through the entire implant. It doesn't come to a dead end and create a dead space and, a potential haven for infection. It is fully communicating. When you put these two lattices together, you've basically got, I'll show you here. So again, we can see these two lattices on the right-hand side, we've got the orthofoam biomimetic lattice. And when that's spinning around, you can see the open pore structure. You can see right through it. The light just comes right through it. And that's exactly what we wanted. An irregular, organic biomimetic lattice that will encourage strong bone growth and distribute load evenly. Then on the left, the perforated TPMS. is like Velcro for the end plate. So it's very grippy. It's very, it'll stick quite well. So the idea is that the perforated TPMS and the testing that we've done shows that it helps it to get that initial adhesion right on the end plates. It grips right on there. Then the orthofoam lattice in the middle, it really helps to distribute the load more evenly of the two end plates to try and address stress shielding and point loading. So when we put that into a spine cage all in one, this is kind of what it looks like. So you can see up the top, you can see what the final implant looks like. Then you can see the gray area is the perforated TPMS, which adheres to the end plates very well. Then the orthofoam biomimetic lattice helps to distribute the load evenly throughout the entire interbody device. And then an exoskeleton helps to basically hold everything together. So we went through 2 years figuring out these lattices, and there was a lot of work that went into this, and we kind of thought, you beauty, look at this, we've come up with something, it's amazing. But then the real work starts, and this is what I want to talk to the viewers about, the designing of an implant, printing some samples and holding it in your hand. That's probably only 5% of the work of getting a device to market. It is pretty common. I get engineers and some clinicians that tinker around and go, hey, I've got this implant that I've printed on a metal printer. I want to get it to market. We've done a lot of the work already. And it's just the design work that's done, which is a very small portion of the total work needed. So in bringing a medical device to market and manufacturing a new spine cage, the number one question after you have a design philosophy is, where are you going to take this thing? Because getting regulatory approval is very difficult, and each regulator requires a different technical file. They require different testing. There are different standards. So you can't just bring a device to market and go, great, I'll do some testing and then I'll get it through every regulator. You need to pick where you're going to go. You need to then put an entire team together to develop technical documentation that is tailored to that regulatory body. So what you submit to the FDA is different to what you submit to the European Union for a CE mark, which is different to what you submit to the TGA to get an Australian approval. So deciding where and how you're going to bring your device to market really will drive all the testing and documentation you need to do. This slide I like because it's what I come up against quite a lot is engineers going, hey, I've got a great device, we've printed some samples, we want to get it to market. That's probably only 5% of the work, right? So there's a few good quotes that say around for a class 2B medical device like a spine cage, it costs around $30 million to get FDA approval. The majority of that is in testing and regulatory documentation and verification and validation. So it's probably only 5% of the total time, effort, and cost is in the design, engineering, and the printing of samples. The rest of it is in all of the testing, which is extensive, that needs to be done to be able to bring a device to market. And this is quite often what sort of academics, engineers, and clinicians might not be that well aware of, is the extensive nature and the standards that need to be adhered to for testing and compliance to be able to build a technical file to get a product to market. So the next slide is, it's not fully comprehensive, but it shows you some of the tests that you need to do right here. So some of the tests you need to do, why you need to do them, what standard dictates that you need to do these tests. So the mechanical testing, the material and chemical, the biological, sterility and packaging, some of these tests are, millions of dollars to do for external labs. Then you get the report back from the external lab. You need to then put that into a format and then justify why this test passes different standards to be able to build a technical documentation suite that you submit to a regulator. So not only do you have to do all of these tests, you then need to comprehensively put them into a technical file with a whole bunch of other documents that makes coherent sense for a regulator to go through and give you regulatory approval. Now, we're still going through this process years later, regulatory approval. It's exorbitantly difficult, expensive, and time-consuming, but it's good for the viewers to know that You know, these medical devices go through significant amounts of testing to be able to get regulatory approval. I'll just put up some happy snaps of what we've done at Additive Surgical. It's a facility in Adelaide. It's about 1,000 square metres. We set out with the vision to build an end-to-end medical device manufacturing facility. Now, the reason why that's important, building something end-to-end, is there's quite a lot of smaller medical device companies that will use outsourced engineering, outsourced printing, outsource clean pack sterilize, outsource post-processing, and they'll outsource everything. They'll get a product ready to go to market, but they don't control anything, right? So we did the opposite. We insourced everything. We wanted to control the entire process, somewhat because of supply chain security, somewhat because of cost efficiency and margin control, predominantly for our regulatory compliance. If we do everything ourselves in-house, we're not at the mercy of external suppliers. And in Australia, we're reasonably geographically isolated. So to do this all in-house is something we're really proud of. One of the other reasons we did this in-house was it's our speed to market. If we were using external printing, external post-processing, our speed to market is significantly slowed down, and our speed of innovation. You know, like I can print these little samples of 3D printed titanium, and we can do that every day. If we're using an outsourced supplier, you know, there'd be weeks in between this innovation. So we set up a facility in a large 1,000 square metre. It's an old rug showroom. We got a team together. We then were able to fit out the facility with a bunch of offices, you know, put a kitchen in, put a bar in, set up a logistics area, develop an ISO Class 6 clean room, set up our 3D printing facility. We had a grand opening, which was lovely. And this is where we are now. You know, we've got teams of engineers. We've got our logistics section. We've got our clean pack and sterilize. We've got our printing section. So that's what it looks like. You know, that's taken us 4 years to put together. And I come back to this importance around vertically integrating a supply chain, right? Because we've done everything in-house, the design and development, the manufacturing, the performance testing, the verification and validation, quality system, which is ISO 13485 certified, and our technical documentation and regulatory. We've done everything in-house to control the process, to increase the speed of innovation, to get our products to market. So it's something I'm incredibly proud of, and our clinical advisory group we've worked very closely with to inform the design and the development of these implants that we're manufacturing. Now, I want to show you the manufacturing process quickly in a couple of videos of our 3D printed titanium implants. So you can see the video here where there's a laser that is literally melting a very thin layer of titanium powder. So a blade will come across and it'll deposit another layer of titanium powder over the implant bed. So that blade comes across and deposits a few microns of titanium powder. The laser then comes back on and melts to each layer. So it's about 8,000 layers. It takes overnight to print. And at the end of it, you get a small cube of a bed of implants. And then those implants, so I'll come to this next slide here. When you're taking the bed of implants off, the rest of the titanium powder sort of falls away. And then you're left with unprocessed, non-sterile implants, which, you know, I just think like how additive manufacturing works, using lasers to melt titanium together, we can create these incredibly complex geometries and these lattice structures, which traditional manufacturing just can't do. So that's the process. That's the laser, then that's taking the powder off, and then they're the implants that are sitting on the build plate. So what happens after this is, you know, this is the printer, the sieving station, the argon gas. Then these are some of the post-processing pieces of equipment. So there's a laser marker to laser mark the implants. There's a heat treatment machine, and that heat treatment anneals, or it lets the metal reduce all its internal stresses, because after it comes off the titanium printer, there's some internal stresses that you need to heat treat to basically relax the metal and make it even softer. And then we also have in-house modulus of elasticity testing. So we've got an Instron machine. We've got a couple of them where we will do all of our tests internally to validate and warrant the performance of every one of our implants. So after all that, this is what we get to. So this is a worst case lumbar cage for a lateral approach. Now, there would never be a cage this big used clinically. This is when we have worst case testing. What that means is we can never make anything bigger than this, and we do all our tests to this, I think it's 16 mil high, 65 long, 25 wide cage. We test and validate this worst case. So anything smaller than that is going to perform better as far as mechanical and structural testing. What you can see here in this cage is along the side of the cage there, you can see the orthofoam lattice. So it looks like trabecular bone. It's irregularly shaped, and that's that's printed very well. And then you can see in the teeth, you can see the Velcro for the end plate. So I'll just get that to spin around, and you can see the two different distinct lattices in the one implant. So it has been quite difficult being able to get these to print, being able to manufacture them. And this is one of the reasons why you don't see a lot of implants that look like this, is because manufacturing is difficult. There's a lot of refining we've had to do and a lot of testing we've had to do to prove that these are what we say they are. So this is nearly it, right? You get that implant, that's what it looks like. You then put it through a clean room where it gets cleaned and packed in double blister and TPU. And then it becomes a finished product, sterile, ready to use in a box, ready to sit on a hospital shelf to help surgeons, to help their patients. So I'll just stop sharing there. So that gives you a bit of an idea around the process of manufacturing a medical device, the philosophy that we've employed at Additive Surgical to really make a better implant to get better patient outcomes with using multiple lattices in one implant.
Thank you very much, Gibran. That was very insightful. Now, Dr. Selby, after this beautiful presentation, if you could please share some of the cases and insights from your end.
Yeah, so I've just got a few cases of why I think that the 3D sort of printed titanium is probably the best that we've got at the moment in fusion. And I certainly recognize there may be things that will come along that are better potentially in the future, but I am just going to, get this going. Just making sure that you can see this. Is that okay?
Yeah, we can see.
Great. I'll just try and put it into presentation mode. Sorry, give me one moment.
Take your time. We have all the time.
All good? Just gonna go back.
That's some cage, Mike.
It is a cage. I'm just going to go. Sorry, just let me resume sharing. I'll just give it one more go. Sorry, it's not behaving. Yeah, look, I think what Gibran's done is absolutely revolutionary in some respects, in that the thought process behind this goes further than just replicating what's been done in the hip. And, you've seen hip arthroplasty, right? And the whole trabecular metal thing and how you try to get that to bond the acetabular component in a hip replacement. I mean, that's what a lot of the original spine implants were based on. And I think there's definitely something in that, in the degree of early integration that you can get. But I think when you look at those particular technologies for some of our older patients in particular, perhaps those structures are a bit firm, they're a bit hard. They don't quite have that same modulus. And so I think there's a bit more nuance to it than just getting in and doing the same as the hip. The spine is a very different environment, and it's not really a mobile bearing or anything like that. So, that's where we've got to look at these things a little differently. I think the other thing is, we've Gibran's an expert on cage manufacturing. Just a side note on, people often ask, can you 3D print pedicle screws, and I was pretty excited about that as a potential option, but have not really seen it come to fruition, I would say. Gibran, what do you reckon about 3D printing pedicle screws? I think the manufacturing machining process is quite different, right?
Yeah, listen, there's a Eminent Spine in the US have got a 510K for a 3D printed pedicle screw, and I'll be interested to see some of their data, but I haven't seen any clinical data on that. And I know that Illuminate in the US as well have got some very promising technology in 3D printed therapeutic hardware. So yeah, it's there. It's going to happen. It's just refining the technology to make sure it passes its testing as far as mechanical strength goes. But yeah, 3D printed pedicle screws is it's a big deal. Tsunami Medical have also launched a 3D printed pedicle screw that, so I can't wait to see where that goes.
Yeah. I mean, and you talk about it though, the actual manufacturing process for a 3D printed pedicle screw and the way that titanium is sort of put through that machine, to me, the way a screw gets inserted, the torsional forces are the potential weak point, right, in that. So you have to work out how to get around that.
100%. 100%.
Because I think we've seen in some local testing, maybe it's not as easy as it looks like it might be.
Correct.
Yeah. All right, good. Is my screen up there? Vertebral views.
Yeah.
Slide. Thank you very much. Awesome. Okay, so why are we talking about this? Well, we're talking about manufacturing of implants because we want the best possible implants for our patients. We want our patients to fuse so that we avoid revision surgery. We want to avoid revision surgery because, number one, it affects the patient, but in particular, it has a high complication rate. You have to deal with scarring. There's potential for higher infection rate, non-unions and junctional failure. And this is a TLIF cage that I took out. I put this one in myself over 10 years prior, and the patient developed a deformity. One of their TLIFs had fused, another one hadn't. Remarkably, they had been relatively asymptomatic for a number of years. So you can have a lot of non-unions that are not actually completely symptomatic. As you can see, there is very little bone growth through this PEEK cage. And you have a look at the external surface, and it develops this kind of fibrous interface with the bone. So as Gibran was saying, PEEK does not bond to bone. It just holds the space open while the bone grows either through it or around it. And if the bone does not do that, you will have a non-union or at best a locked pseudarthrosis, which is kind of like a non-union where the bone's grown from each end plate, but not completely joined in the middle. This is how some PEEK cages have to come out. So this was a little bit more stubborn. I had to use the osteotome. This is a different PEEK cage. So yet another case. I've got a lot of these. I spent a lot of my time taking out PEEK and other cages. This is another one. This is my current wonderful fellow, Dr. Kitaro Minato from Japan. He has a cage we took out just the other week. This is an L45 non-union, and you can see here on the accompanying films that this young patient had had a 4.5, a TLIF done. Everything looked good, and it did, but the patient has ongoing pain. And it's only a bone scan with SPECT done 3 years later, showing quite significant activity across there that is really completely diagnostic. They didn't really have majorly loose screws or anything like that. So this was a significant non-union, and there goes the PEEK cage out via an anterior approach to revise it. So when you're talking about these, and this CT is just rolling through there, but to me, I cannot see any major haloing around those screws. I think the other thing you can't see here is a fusion through the facet joints when you look at that CT rolling through. So that's another good clue that things may not have worked as we hoped. But I'm not just going to pick on PEEK. This is a patient who is an 80-year-old female. She's had 4 prior spine surgeries, including decompressions, TLIFs, and extension of TLIFs. And she's now got further adjacent segment disease at L1-2 and L2-3 with a non-union of a TLIF at L3-4. But she is solid, L4-5, where she's got a PEEK cage, and L5-S1, where she has a titanium cage. Now, why am I putting up a case of titanium when we've just been talking about how good it is? Well, nothing's perfect, number one. Number two, I'll flick through and I'll show you what this cage looks like. So she'd had a lot of medical comorbidities. She'd had a spinal cord stimulator, but she still came in with severe lower back pain and couldn't stand up straight. So these are her pictures. She's leaning forward, positive sagittal balance. She's got a spinal cord stimulator in there, and you can see the adjacent segment disease at the cranial 2 levels. Also that non-union at 3-4. So we got in and did a prone lateral revision, and I'm operating here with Simon Clark, who Raj and Gibran know. He's one of my neurosurgical colleagues here in Adelaide who does understand bone biology. And we're doing a posterior revision here, just removing those posterior screws. And at the same time, we're able to do a prone lateral. So this is the power of prone lateral surgery in a revision like this, is that we're able to get this T-lift cage out through a lateral approach, whilst also controlling and operating on the back of the spine to remove those existing screws and upsize and extend the existing hardware. So this is Simon distracting through some screws while I'm in the lateral space trying to get this cage out. It was a bit stubborn, this cage. It was a titanium cage, and although there was a non-union, you can see it there, and you can see it at the bottom of the prone lateral retractor there. But this is I think, a bit tricky to get out, but eventually it came out. So you can see us using the hook there for hip revision. So this is a hook that you use to get cement out in revision hip surgery. There's a whole bunch of them there that you can also use to extract cages. But this is a slightly older 3D printed titanium cage. So this lady's come in many years after this surgery, and this is not that rough. So you can see after I've pulled it out, so this is all her implants that came out, and the top there is the cage, right? And you can see in the cage is still some bioglass kind of stuff that was used that never fused. And then you can also see that it's smooth. So although this cage was made out of titanium and was 3D printed, it is not roughened properly on the end plate. So it doesn't get that grip, right? And then also just the way it was sort of implanted, I don't think maybe enough disc was cleared or a few other things that could have been done better. But people will go, oh yeah, I see titanium, it doesn't fuse. And they're right, titanium doesn't fuse. But when you now move towards these better designed cages, I find it hard. I would find it very hard to find to notice a non-union I had that's due to pure non-union, not infection or any other problem, of a titanium cage in the last 4 years of the roughened type. And this is her final revision. She's 80 years old, so we haven't gone for complete sagittal correction here. This is a minimally invasive revision effectively, but she's done very well at now 2 years after this last surgery. This is another case. This patient has not had revision yet, and in 2019, they had 2-level ALIF on the left done with plates and PEEK cages, so it's standalone 2-level ALIF. And by 2015, you can see that CT in the middle, there's a non-union at L4-5 of these PEEK cages. There's no bone growing through the middle of that cage. And you can see the big gap in the fusion mass. And at the top of that PEEK, you can see the loosening and haloing of the screws around the plate. This is a great slide because the level below also has technically a non-union, but this is a locked pseudarthrosis. So the locked pseudarthrosis is where instead of no bone growing and the implant being loose at the end plate bone interface, the implant is actually solid at the end plate bone interface, but bone grows through each section and tries to join in the middle, but never quite gets there. So the locked pseudarthrosis is a type of non-union that many patients can have and actually be relatively asymptomatic with for many, many years. And we see this all the time in PEEK cervical cages. What I find is absolutely diagnostic, particularly beyond 3 years and probably beyond 2 years for non-union, is bone scan with SPECT. So you get a high quality bone scan with SPECT, like this one in the bottom corner here. So this is 5 years after the index surgery. Surgeon told patient everything's fine, everything's not fine, lots of pain, and you can see that that scan shows a grossly positive bone scan at 5 years. So this is an absolute non-union and needs to be fixed. Hasn't been fixed yet, that's incoming. It's one of my cases. So one of my patients came back this week and I thought this is a great opportunity to put up a scan. So this patient is almost 2 years after I did a 2-level anterior fusion with posterior pedicle screws and rods. So it's a 2-level ALIF, and you can see the bone growth here through the cage on the CT. You can see that sort of solid column growing through, and you can see how these cages integrate with the end plate. All right, so that's the roughened titanium integrating with the end plate. There's no loosening there at all. And you can see a bone scan because she's around that 2-year mark. There's a tiny bit of activity through those cages, still nothing like the bone scan you saw previously. So this is normal bone remodeling, which, you know, in an 80-odd-year-old patient does continue for between 2 to 3 years after a normal stable fusion. But the reason I did the bone scan was to investigate her adjacent level, which you can see up the top there has a little bit of heat on it. And look, we may have to do something about that in the future. She's just having some injections at the moment. So it just gave me an opportunity to do a scan on a patient I was pretty sure had fused at the levels involved and show the differences there. So just one more case to run down quickly. This is a 68-year-old female who had a T12 fracture about 3 years ago, and she's got a T-score of -3. So she's got terrible bone density despite treatment. And you can see there she's got a focal kyphotic deformity at the thoracolumbar junction, and she's flattening her thoracic spine and really recruiting all of her pelvic compensation mechanisms to compensate for this. It's not a disastrous deformity. It's not a huge deformity. She's got a little scoliosis, but she has a lot of pain. She's got about a 34-degree focal kyphosis. So again, not terrible. All right, so the question here is, what do you do? And number one thing you have to do for these patients, if you're going to operate, is work them up and optimize bone health. So you can see here, she's got a pretty significant fracture, and it just hasn't healed. She's got a non-union. And although she's got that little bit of bone sort of in the canal, she doesn't have any major lower limb symptoms, but she does have a T11 radiculopathy. So she's got irritation of the T11 nerve roots as it comes out at that T11-12 disc level. So this is what I did for her. You know, I'm not going to harp on about this, but this was actually a prone lateral through the chest. So this is a minimally invasive reconstruction where I've gone through the chest. We've removed the T12 body, scraped out the disc at 11, 12, 12, 1, and put an expandable titanium 3D printed cage with roughened end plates. Okay, and this has restored her reasonably well. We've still got about a 14-degree kyphosis down from 34, so we've gained 20 degrees. You can see that she's now restored a bit more of her natural upper thoracic kyphosis, and she's been pretty good overall. She's a very skinny patient. She actually came back to me because she's got a little bit of irritation over the screw heads at the back, which we may end up having to take out. But that gave me an opportunity, and in Australia, we're very lucky to be able to follow up and get CT scans very easily. So this was a CT scan for this patient at 6 months post this reconstruction. So this is a patient that we've got with terrible bone quality. She's got screws at the back that are MIS cement augmented. And you can see on these slides that she has a pretty solid fusion already at 6 months. Okay, so you can see the bone growing through the middle there on that top right shot. And there are a few little bit of bioglass chips in there, but this is mainly bone, allograft bone graft. You can see the integration of the end plates of this roughened titanium end plate expandable cage device. And you can see the facets at the back have also started to fuse completely. So I'm pretty confident that as these screws are irritating this lady, I'll be able to take them out in about 6 months. And just give her a really good result overall. But I just thought I'd show a couple of these cases to see, you know, why I've changed my practice a lot. And I certainly started out using PEEK and carbon fiber cages, and I have completely shifted to 3D printed titanium for every single interbody device, whether it be an expandable cage, expandable corpectomy cage, static ALIF, static ACDF. I use this every time now. So yeah, happy to take any questions, and hope that put a bit of clinical context into what Gibran was talking about.
Mike, if you allow, can I chip in with a question?
Of course.
Yeah. So the standard method of assessment of bony fusion interbody on CT scan is by the Bridwell method, where you see how the bone is bridging out. But with these kind of 3D printed cages and the complex lattice structures which Gibran mentioned about, do we have an objective scoring system or a reporting system which will enable us to diagnose whether it has fused or not? And plus, how do you take in the false positive and false negative reports which come in with a SPECT CT added to these?
Yeah, this is a great question. So I think it's really hard on a CT scan to determine if there is complete union or not purely by bridging bone. You can often see that bridging bone when you're looking through the scan. But sometimes it's obscured by metallic artifact. It depends on what sequences your CT people are using. And sometimes the CT people, because they want you to see where your metal work is placed perfectly, of course, every time, but where they want you to see where it's placed, they use an artifact reduction sequence actually suppresses out bone a bit. So you have to talk to your radiologist and see what sequences they're using, right? The second thing is there are always clues in these scans, particularly when you get them late down the line. And so if you're worried about a non-union and you've used a 3D printed titanium cage, you may see that the end plate isn't quite fused. And so you see a lucency at the end plate or around there, or the facets aren't fused at the back, or there is still gas within the space. So if there's still gas within the disc space, that's always a sure sign that it hasn't fused completely. So I think we've got to look at those secondary things, because I agree it's really hard on CT scan to see. Now, sometimes you can see a smooth column of bone at the front or the side of the cage, and that's when you go to the cervical spine. You look at the work by Dan Ryu, which was excellent. So Dan has got into this a bit more in the cervical spine, and basically said, if you can see bone through a cage, it doesn't mean it's fused in the C-spine. It might just be graft, tricalcium phosphate, Vioglass, or bone chips that you've put in there that are still sitting in the space. He said you have to see fusion of the uncinate processes either side, and ideally fusion at the facet joints. And then he feels that flexion extension is a more accurate way of assessing union. And so I think that's also a good option to always go back to good old flexion extension. I think with high resolution and standardized x-rays, we can get good results out of flex extension. So the final thing is, well down the line, the bone scan with SPECT can be really helpful.
So, but how does the fusion occur at the posterior elements when you have put in MIH screws, prepared the anterior disc space, haven't curated or debrided the facet cartilage? How does the biology work there? How does it fuse or fuse?
So often they just auto-fuse those facet joints, but to be honest, most cases, I often just gently drill the edge of the facet joint through the same incision we put the screws in. So I'm not doing a big posterolateral decortication, but we're just drilling those articular surfaces that then get compressed together.
Thank you very much. Dr. Selby, so will you be so kind now to share with us some of the tips and tricks that to remove those non-united cages and implants?
Oh, yeah. Okay. That's a whole talk in itself. Raj will have to have me back. But yeah, as you saw there, I think when you're removing a T-lift cage, and I've tried to do this from the back before, you end up really destroying the end plate if you try to take it out the same way you put it in. Unless it's pushed itself out the back, which they can do sometimes, you know, to get back in there is hard, right? Often the screws that you use to kind of open up that space are getting loose and stuff, and then you're really trying to fight the loosening of screws while you reopen a space around a scarred nerve root. There's nothing pleasant about it. So my big advice to revise any failed T-lift or PLIF is to get back in the anterior space. Now, whether you do that via a direct A-lift or an O-lift, or a lateral, depends on the level, depends on your skill set, and depends on who you have available. Also depends a bit on the size of the patient and the vascular anatomy. But you really want to get back in there and get an anterior column reconstruction type device in there after you've pulled the thing out. Now, if it's really loose, they often just fall almost straight out. But a lot of them do have a bit of a fibrous interface with the bone. And that fibrous interface comes off really easy just with a small osteotome. You don't even have to tap it. You just kind of work it in. If they're a bit more wedged in there, then you can have to use a bit of x-ray just to make sure you're not taking too much bone to get really beyond it. And this is where those good old orthopedic cement removal tools come in really handy. So I think you saw some of them in the video I put up, and some of the spine companies actually have them now. It's just your orthopedic cement removal hook, and you can hook them in to the apertures on the cages and then just tap them out with a mallet.
It's really wonderful. So before we wrap up, just a final question to Gibran and Mike, to both of you. So the world trend, the global trend is going to avoid the peak cages as much as possible and going towards the titanium. But if you have to kind of prioritize or give points, which are the cages you'll prioritize? 3D printed versus 3D printed titanium, peak, how you'll rank them for current scenario? Gibran.
Obviously not being a clinician myself, you know, and having bias because I'm dedicating my every waking moment to commercializing advanced 3D printed titanium, you know, that's where the literature suggests everything's headed. But, you know, I'll defer to Mike for a clinical perspective.
Well, look, I think we have to have a clinical perspective of not every one of us is going to be selling implants in the US, right? You know, the biggest market in the world that pay a high price. I mean, we're spine surgeons all around the world, right, doing these things. And, you know, the prices that are paid for medical devices in Australia and US is completely different, even from Europe, even from the subcontinent, you know. And, you know, I think the refinement of 3D printing to make a high quality product that fuses well in patients from all around the world is a huge advance, right? Because you can have local manufacturing. You're not dependent on overseas companies, overseas IP, overseas supply chains. So whilst you're seeing this, a glimpse into the last 5 years of Gibran's manic life, it's a it's a huge process. It can be done. That's the point. You know, you don't need to just rely on the big companies in the US. And you know, sometimes you're at their whim. I mean, we had Johnson & Johnson just pull spine out of Australia. Just left. You know, and Australia's a big market, right? So, you know, you can't, I don't think we can always take supply for granted. That's what I'm going to say. And I think being in control of manufacturing and knowing about manufacturing and the process as a surgeon, it's really opened up my eyes, and it's been a really valuable journey so far, but it continues.
Thank you very much, everyone, and thanks to all the viewers across the globe who join us in huge numbers as always, and we appreciate your support. Thanks, everyone.
Thank you, Gibran. Thank you, Dr. Selby.
Thank you.
Thank you.
Thanks, Angelica. Thanks,
you.
Raj. Appreciate it, mate.
Thank you. I
very much.
appreciate it. Mr. Rushi, we can go offline, mate. Rushi, you there?
Do we need to stay or should we hang up?
We can hang up, mate. That's fine. Thank you.
Okay, thank you very much. See you.
Thanks, guys. See ya.
Bye-bye.
Bye-bye.
Thanks, Raj. Oh, are you going to be, you're going to be SRS?
Yeah. So kind of committee member and things, and helping them with social media and things. So we are doing this see you at SRS Charlotte and getting great response. I was not sure if you're coming, so maybe we'll touch.
I'm going for a day. So I'm going to have a hectic day. I don't think I'll make one talk. I've got like 50 meetings sorted out. Hey, Raj, I'm sitting out here at the moment.
So this is beautiful. I think this is the best place. If you could share us the video, see you at SRS Charlotte. I'll send you the sample, and
I'll make a little video from down here.
Yeah. See you at SRS Charlotte. That will be perfect.
Thanks, Raj.
And thanks, Mike, for your time. I really appreciate it. I
Is
think
that all right?
thousands and thousands. Yeah. If you show us the beach, that will be perfect.
Good. No
In
problem.
the video.
Yeah, I will do. Okay. Thanks, mate. Thanks, Gibran.
Thank you. I appreciate your time and expertise.
See you guys.
Thanks. Thanks, Raj. Appreciate it. Raj, are you going to be in Denver going to the NAS meeting?
Most probably not, but let's see how it goes.
Okay, no stress, man. Anyway, thanks for your time, mate. Really appreciate being on the segment.
Thank you.
It was great.
I might be in Perth soon. Let's see.
Yeah, stay in touch, man. Just message me anytime, all right? Be good.
Cool. See you, mate. Take care.
Yes,
Thanks for your time.
bye.
I appreciate it. Bye-bye. Rishi bhai.
हेलो सर।
तो लास्ट वाला पार्ट थोड़ा कट कर देना अगर पॉसिबल है तो।
हाँ, यूट्यूब से।
हाँ, अगर पॉसिबल है तो, वरना इज फाइन, कोई प्रॉब्लम नहीं। और
ठीक है
बाकी
सर।
क्या चल रहा है तुम्हारा? क्रिकेट वगैरह खेल रहे हो कि नहीं?
बस सर